Hello, kidney warriors. James here from Dadvice TV, your online kidney health coach, and this is Dadvice TV Live. Now, for those of you who are new, let me quickly introduce myself. My name is James. I'm a kidney warrior. I've been living with kidney disease that I've known of. A lot of times you get kidney disease and you're not diagnosed until symptoms start showing up. But I've been living with it for 5.5 years now. I was in some bad shape when I was diagnosed, but I've worked with my doctors. I worked with my dietitian on my diet. I got my blood pressure under control. I've started staying active, and I feel fantastic even with bad kidneys. Now, today we are going to talk about a very common topic that people ask about all the time. How can I avoid dialysis, or at the least delay dialysis? Because one of the saddest things is when a person is put on dialysis early or too early. Now, to talk about tips and techniques that you can use starting right now on how to delay and maybe even completely avoid the need for dialysis, I have with me a very, very regular guest that you all love. He is the author of the #1 book, in my opinion, about kidney disease. And this is a book that should be on everyone out there's shelves for kidney disease. It is called Learn the Facts About Kidney Disease. This makes understanding kidney issues easy. It takes out all the fear and confusion. If you're worried, what the heck should I be eating? Dr. Rosansky talks about his smart diet in here. It is super easy to understand and to follow. You're going to absolutely love his book. But let's get to the good topic today. Let's go ahead and welcome my co-host today, the one, the only, Dr. Rosansky. Hey, Doc.
Hey, James, I feel like I should do a dance. Da, 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 da,
Hey,
da, da,
you're
da, da,
awesome. So I built it all up. Woohoo.
Oh, boy. Always good to be on your show, James. And this is one of the most important things I'm doing in my retirement. And I have to thank James for reading my book and loving it. I mean, that book that he just showed you came out in 2020 when COVID hit. And James gave me an opportunity to get it out to the public, which was very difficult at that time. And we're going to talk about one of the main topics that got me to write the book, the issue of when to start dialysis. And just a little background, I'm a retired kidney specialist. Not only have I taken care of kidney patients for over 40 years, I still see people in the free clinic. I also am what they call an academic kidney doctor, in that I've done a lot of research, published over 100 papers. My work has been recognized pretty widely regarding the issue of when to start dialysis. My paper was the #1 game changer in the field, but unfortunately the game changer would have been for people to be starting later, but that's unfortunately not happening. And so the more I can get the word out to you folks, the happier I am. The other thing that I wanted to do is to get you to not worry so much, because many folks worry about their kidneys. They have very mild kidney disease that's never going to require dialysis or kidney transplant. And that's another thing that you need to look into my book about, or listen to some of our previous shows. We talk about that a lot. And tonight we're going to talk to you, everybody, because everybody worries about dialysis, who watches this show. I would guess the vast majority of you. And then this is especially dedicated to any of you whose doctor has mentioned, you may need dialysis. This is critical for you. Please pay attention to this talk, all of you, but especially those who dialysis has been brought up. And please get my book, especially for those of you, if your doctor has talked about starting you on a kidney machine. Really important for you to consider getting my book. So, way too early, in my opinion. A lot of doctors, kidney doctors, are discussing the dialysis issue, and they discuss it when you have so-called CKD4, and these are arbitrary definitions. It's just based on your kidney number, your EGFR, and hopefully those of you who watch the show are familiar with that. EGFR is the estimated, what, James?
Glomerular filtration rate. And the most
James has
important
got it.
most important letter is that E, estimated.
Brilliant, James. You're right on. You're right on. It's just an estimate, folks, and that's important to know. And we're going to get to that again. And, you know, doctors discuss it. CKD4 with the estimated kidney number is somewhere between 15 and 30. And then they get real hot to trot with CKD5 when your kidney number is below 15. But, folks, you can be in these ranges for years and years. No rush to go on dialysis. And remember, I like this one, James. The trend is your friend. What do I mean by that, James?
We don't focus on single digits because our GFR is going to bounce around. We watch the trends.
Perfect. That's perfect. Yeah. Because I've seen people, and I continue to see people in the free clinic who may come in with a CKD3 or even 4, and then I check them again, and they don't have CKD, or they go from CKD4 to CKD3 or CKD5 to CKD4. You've got to look at the trend. You've got to get repeated values, because one value, don't panic. Do not panic. And there are many, like James, who experienced something where they almost put him on a kidney machine, because when he went in the hospital, he had bad kidney function, but it was a temporary deal. It's called acute, meaning it's going to reverse. And everybody wants to know when kidney disease can be cured. It's cured, essentially, I put cured in air quotes, when you've got some kind of temporary decline that can reverse. And we're going to get into that again tonight. We've talked about that in several of our other talks. And to me, one of the biggest mistakes that my colleagues have done is to call stage 5, which is EGFR less than 15, kidney failure. I think that was a big mistake, because people say, oh, I got kidney failure. Get me on a machine. Don't rush it. You definitely don't need to get on a machine when you're 15, or, you know, and we'll get to this in a little bit, but you may not have to get on until you're below 5. But let's hold that for a minute. And those of you who say, well, I got this problem, I got that problem, and my GFR is 15, or it's 20, or it's 12, or, you know, whatever, and I'm going to get on a machine, I'll feel better. Wrong-o. Dialysis is no fun. There's no need to rush it. If you got a good reason to get on it, great, go on it. But that's rare. It is extremely rare that any of you folks have to start as an emergency. And like I said, the best time to live the longest, maybe going on at 5 or less. And this is rare in Western countries. And one of the reasons is, James, you can say it, or you want me to say it. One of the reasons why it's so rare is what?
Oh, sorry, I was reading the comments.
Okay. One of the reasons why it's so rare for people in this country to wait that long to go on dialysis, GFR 5 or less, or in the 5 to 10 even range, why is that so unusual?
Why is it so? Well, because the doctors are pushing it earlier because it's covered by
It's a
Medicare or
business.
Medicaid.
It's a
Yeah, it
business.
makes money.
Folks, every medical specialty is a business. And you've got ethical doctors, but we're still in business. Remember, it's a business. And there are dialysis units, especially in the Western world and especially in this country, on every corner.
Yeah.
And there are big corporations that want to continue to make their billions, and they're putting people on dialysis, in my opinion, in many cases when they don't need to go on it. There's no need to rush dialysis unless there's a specific reason, which we're going to get into. And I'm not the only expert on when to start dialysis. I've got colleagues that have done research just like me. I told you my paper was voted #1 game changer, but there's other papers that found very, very similar results. And there's no reason to start just by your number. Don't let people get you hung up on a number. Say, you got to go on a machine. Say, Doc, I read Dr. Rosansky's book, and this is what he says, and this is what all the research says. Let's go over it, Doc. So, what's the first thing to do, and what's the first thing you need to know when we're getting into what you should do about your kidney function issue? What is one of the things we talk a lot about, James? We already mentioned. I'll tell you. It's the inaccuracy. The inaccuracy of a GFR number. And we already mentioned it. James brilliantly told you that your doctor's taking a blood sample, and James is showing you how these numbers vary, and they do, just like James said, just like the waves in the ocean. They go up and down. I totally agree. They get it from an equation, and over the years, folks, I'm embarrassed to tell you how many different equations my colleagues have come up with. And so you got the business people that want to put you on dialysis because there's more money to be made. I mean, one of the reasons. I mean, that's a reality. Then you got the academics like myself who want to produce more equations so you can write more papers to get into the academic literature. So all this stuff drives me crazy. But let me get to the basics, the equation. There's a number in the denominator, and I hope you folks know the numerator is the top number, the denominator is the bottom number. If you divide something by the denominator. And what number is in the denominator, James?
Is that the creatinine number?
Yes, the creatinine number
Which is a small number.
Right. And normal creatinine is around 1. Minimal changes in that number between 1 to 1.5 can cause massive changes in eGFR. You can go from 60 to 40 to 60 to 80 with very little change in that creatinine number. And that creatinine number can vary by 10 to 30%. So again, don't get hung up on any particular number. So the lower the creatinine number, theoretically, the higher the estimated GFR in the equation. Okay, that should be pretty straightforward. Now, what is creatinine? We need to throw that out, get it clear. People get confused. What is creatinine, James?
Creatinine is natural. It's not bad for you. It's from the breakdown and use of muscle. Your heart beating creates creatinine.
Perfect. It's just a normal substance. I mean, it doesn't have anything to do with kidneys per se, other than it's something that is filtered by the kidney. So you want to get the filtration rate. That's all it is. Creatinine is filtered, gets you the glomerular filtration rate. And all of these things that say, we're going to get into this again in a little bit, James, your favorite topic. We got things to get your creatinine lower. You got to lower your creatinine.
Here's a pill, $100 to lower your creatinine.
Fooled. That's nonsense. It's absolute nonsense. So we talked about the equation, the fact that the different labs use different techniques, different equations, and the numbers could vary a lot depending upon you go from doctor to doctor. And again, the number can vary a lot, can vary easily 10% up to 30% from one blood draw to another. And so here we go, your favorite topic. We see all of these things that can heal you, folks. I just looked it up tonight, James, just for the heck of it. On Amazon, our buddy. Amazon's got kidney superfoods. They've got kidney cleanse. These are all pills you can buy.
I'll tell you, Doc, I don't understand the cleanses because they act like your kidneys are clogged and they got to unclog them to work.
It is total woo-woo. Kidney support, kidney pro, kidney complete. I mean, these things are going to run you $40 for useless things and potentially dangerous things because you don't know what's in them. There's no FDA regulation. Nobody regulates what these people put in these bottles. So be careful and don't waste your money. And this is nonsense. And please don't fall for it. Okay? All right. Back to the show. a little commercial digression. So, okay, so James mentioned that number in the denominator, that's the creatinine. The higher the creatinine, what happens to the GFR? As his creatinine goes up, the GFR goes down. Okay, so you got to know the equation is for the average person and the person who's stable in terms of his muscle, body muscle. And what the equation does, very simply, and I won't bore you with numbers, but they produce fudge factors because males have more muscle than females in general, so they have a male-female fudge factor. And as you age, and this is critical, we lose muscle mass. And I will say this on every show I'm on, James. Exercise is the way to reverse that. And it, to me, is the fountain of youth. It is the one thing that will help all of you because everyone with kidney disease is at risk of dying early of heart-related issues or stroke-related issues, heart attacks and stuff like that, heart failure. So do your exercise as much as you can do. You don't have to be at the gym every day like me. You can do walks, you can do gardening, anything to get regular exercise. Get off the couch, move around the house. Even if you're in the office, get up and down, walk the stairs, because all of that will help you live longer with your kidney disease. The other thing is to adjust for is race, but they took that out because of a lot of controversy about what race really means. But generally speaking, African American patients, in my estimation, have more muscle mass than Caucasian patients, and that's why we had a fudge factor in it. Those of you watching who are African American, the one good thing about taking out race in the equation is that you get a good thing. I don't necessarily think it's a good thing, but you get a lower number. Because it used to be we increased the number with the fudge factor for race. Now you get a lower number, which allows you to go on the transplant list early. This was one of the big reasons that they pushed it. Anyone, especially younger folks, if you have a GFR of 20, get on the transplant list. The longer you're on that list, the higher your priority. And so now African Americans can get on earlier. But guess what? And this is me being cynical again, but it may not be wrong. The new equation, you get lower numbers, and you're going to be winding up getting pushed to dialysis sooner.
Oh, sooner, yeah.
That's the other side of the coin, right? So you got to have a correct measurement, and you need a stable diet, because if you are eating very little protein, and people push these low protein diets, they push these protein supplements with very low protein diets. What's going to happen, folks, when you go on these diets, very likely you're going to become relatively malnourished, lose muscle mass. Okay? When you lose muscle mass, your creatinine goes down. When your creatinine goes down, it looks like your kidney function got better.
Yeah,
but it
GFR
hasn't.
goes up.
Okay? Yeah. Isn't that interesting, James? Yeah.
Hey, it's the same thing if you're in an accident and your legs are amputated. Your creatinine will go down and your GFR will go up, but your kidneys are no better.
Yeah. Yeah, absolutely. And that's exactly right, James. So, on the other hand, very high protein diets can theoretically raise your serum creatinine, and so you need to be at the same muscle mass. So if you've had an illness and you've been sick, you've not been eating, you lose muscle mass, you're going to have a change in kidney function that has just to do with your muscle mass loss, which actually can show a higher level of GFR, producing less creatinine. And hydration is important. So if you're and we're going to get into this in just a minute, if you're dehydrated, stands to reason, you're going to have that creatinine go up. Okay. And you can actually have a decrease in kidney function with dehydration, which we'll get to in a minute. But folks, no need to be taking gallons of jugs of water so you could dilute your creatinine and go to your doctor and fool nobody. Okay, that doesn't do anything about finding out how your kidney function is doing.
Yeah, you're just lying to yourself if you overhydrate to try to get your creatinine down.
Makes no sense.
That's like putting tape on the gas gauge on your car so you won't see it say empty. And wow, it doesn't say empty. I'm probably full because I am lying to myself. It doesn't work.
Very good. I like that analogy. And if you're one of these folks, and I see a lot of people like this, their number bounces around a lot. And sometimes because of that, you can use another marker. It's called cystatin C. It's another way to measure estimated GFR with another marker. So you can ask your doctor if you're both confused, the number's jumping around. Say, hey, doc, why not do a cystatin C? And the last choice is something that James loves to do, to actually get a measured measure of kidney function. And how do we do that?
Is that the urine one?
Yeah, collecting 24-hour urine, which is a mess. But that's the old-fashioned way. And if you do it correctly, you can actually get the real measure of your kidney function. So let's spend a little time on some of the reversible declines.
Yeah. Now, before you jump there,
I
just want to emphasize one thing for the people listening. Knowing the exact number really doesn't mean anything. So even finding out that you are a 52.7, which I've seen them even use decimals, doc, doesn't really help you as a kidney patient. So don't feel compelled to have to do a test where you get an exact number, because it again is only for that snapshot in time. And there's nothing you're going to do with that number. There's no, I'm a 53, I do this. I'm a 52, I do that. There's nothing that exists.
And there's another issue, James, while we're on this. Let's say you're a 60, which, by the way, most labs are not going to give you the number because over 60 numbers are totally unreliable. So let's say you happen to be 60. The real value, your real value, is anywhere plus or minus 10% easily. It can vary easily. I told you up to 30%, but easily 10%, right? So if you're 60, what's 10% of 66? So your real number could be 54 or 66. It's the same number because it's not exact at all. And James, I'm glad you brought that up. So the first thing that is common, that people get reversible kidney failure where their kidney function goes to CKD 4 or 5, similar to what happened to James, is dehydration. Big one, a biggie. Not eating, you're sick, you're vomiting, you're having high fevers, you've taken too much of your diuretic pills that hasn't been regulated. That can give you a drop in your kidney function, a drop in your kidney number. Another common thing is people, when they first start on blood pressure medicines, if the blood pressure goes down too fast or it gets down too low, another common way your kidney number can go down. And remember, and I'll say this again tonight, most of you have high blood pressure, most of you are on blood pressure medicines, and look at my blood pressure talk, because the first medicine that you all should be on is an ACE or an ARB. Can't go through any of our talks without talking about the ACEs and the ARBs, which we'll get to again in a minute. James' favorite topic. That's the number one thing you should be on. And then you can add other drugs like amlodipine or beta blockers and so forth. But you should all be on an ACE or an ARB as the first drug for all people, and certainly for kidney patients. And the goal blood pressure, a young patient around 120 to 130. Older folks, around 130 to 140, a gold top number. And if you're feeling not so good, you're feeling weak or dizzy, check that blood pressure. Check that blood pressure. Don't give yourself a AKI. In other words, don't put yourself into kidney failure by allowing your blood pressure to drop into the 60s or 80s. All right? You're not feeling well, hold the medicine. Another way that many of you older folks out there can see a marked decline in kidney function is when your heart gets weaker. And sometimes this can be episodic. You can have a bad episode of heart failure, your kidney number will get worse, very common. You treat that heart failure, kidney number can improve. And then there's a bunch of drugs. We're not going to get into all of them. What are the commonest ones that people out there are taking that can drop their kidney function, and then it reverses?
Well, that is one of the ACE or the ARBs, right? It's
Good. Well, that I don't know. That, you know what, James, you may be right, but we'll get to that next. I'm talking about other than medicines used to treat kidney disease, which we're going to get to in a minute. I'm talking about usual stuff that people take.
Would it be a diuretic? Is that what you're looking for?
That's used to treat blood pressure. I'm talking about headache remedies, NSAIDs, your
Yes.
ibuprofen, your naproxen, your Aleve, your Advil, your Motrin. Very, very top on the list, especially if you're dehydrated, to bump your creatinine up and drop your kidney number. Hydrate it, get off the medicine, get better. Other drugs commonly that could do it, antibiotics, a bunch of those. Some of the stuff we take for ulcers like Prilosec, Nexium, Omeprazole, and chemo. There's a lot of drugs which we don't have time to get into. A lot of drugs could theoretically do it. Commonest ones, I think, are the NSAIDs. Now, what if you're a man? What's a common way to get reversible kidney failure in a man?
In a man? And first thing that pops is dehydration, but that doesn't have to do with the man.
Only men.
Oh, I think I probably know this, but I cannot remember.
Our prostates get bigger as we age, and that blocks the flow of urine. Urine backs up, and that can easily cause you to get a decline in your kidney function. Put a catheter in, and you do it right, and you let the urine out, and you're cured, okay? So, now this is a trick question, James, when is getting a lower GFR on a lab test, when could that possibly be a good thing?
I don't, never. Can I think of that being a good thing?
Well, if you go on now we have several classes of drugs that slow decline of kidney function. We used to just have two classes of drugs. They were the ACEs and the ARBs. And I'll go over it again. And the ACEs end in pril, like captopril and allopril. And the ARBs end in tan, like losartan, candesartan. They're interchangeable. That should be the first drug for lowering blood pressure. And they were proven 30 plus years ago to slow decline of kidney function. First proven in diabetics, but also in non-diabetics. And this is especially the case if you've got significant protein in the urine. When do I call it significant? If you're consistently at least 1+ on your dipstick, and you're consistently over, let's say, 200 on the spot urine. In other words, the doctor says, give me a tiny bit of urine, I'm going to send it to the lab, and the lab will measure the albumin in the urine, that's a kind of protein, and the creatinine. And that ratio, if it's over 200, that's significant. If you're outside of the US, if it's over 20, that's significant. So we've got the ACEs and the ARBs and the other newer classes of drugs that slow decline of kidney function.
SGLT2s?
Brilliant, James. You're on it. And the other two classes, and this is all very recent,
I wrote them down the last time we
That's
talked
that's
about them.
the weight loss drugs, which are called GLP-1s.
Yep.
And at the end of the talk, I'm going to mention this. You can't give a talk these days without talking about the weight loss drugs, because everybody's going crazy about them. The GLP-1s, the weight loss drugs, and the aldosterone blockers. Okay, so now it used to be you just had the ACEs and the ARBs. Now we've got a bunch of other drugs that may slow decline of kidney function. But I'm getting to the punchline. What they may do also is have your GFR go down when you first start the drugs. Does that
Right.
ring a bell, James?
Yep.
That's what I'm getting at.
And it's expected. So they keep an eye
Expected,
on it.
not unexpected at all. Not everybody, but
Yep.
what experts like myself, and there's been a lot of us getting together and discussing this ad nauseum, is that look, if you decline even by 30%, that's a lot. And when you first start these drugs, that's not a reason to discontinue them. You got to follow it. You got to watch. Your doctor has to watch. And this has been studied, folks. And they found people 3 years later who doctors got scared. And all the drugs I mentioned, whether it's the aldosterone antagonist, whether it's the SGLT2s, the ACEs, or the ARBs, the drugs that may help you can initially cause some decline in GFR. But those people who didn't restart them, they were harmed. They lost kidney function more quickly than those who stayed on them. So it's important. And if you're one of those people, discuss it with your doc. Now, then the anti-aldo drugs. I think James is on one of these. Remember the one you're on?
Okay, hold on. On the aldosterone ones, yes, spirolactone.
Spironolactone. That's the old, very cheap version of the newer, very expensive version of what they call an aldosterone blocker. The new, sexy, expensive version is finerenone. For my money, I'm good with the older ones, the spironolactone or pleuronone. But they may raise your potassium. Remember we talked about that?
Yep.
Aldosterone gets rid of potassium in the urine, puts sodium back in the blood. So if you block it, you're not getting rid of the potassium. But you know what's interesting? The SGLT2 drugs seem to counteract that potassium thing a little bit. So they work well together. And they're going to get cheaper. I know a lot of you folks, these drugs are not necessarily covered by insurance and they're expensive. But the ones that the ACEs and ARBs are not. All of you, there's no excuse. You need to be on an ACE or an ARB if you've got high blood pressure, and especially if you've got any kind of significant protein in the urine. Now, let's go right to the topic of the evening. What if your doctor mentions dialysis? And I'm going to break it down to those of you who are younger and those who are older. And obviously,
now you got to define older, doc. Always got to define that.
It's the old story, James. Older is like 10 years older than you are. But now exactly. I'm 77, so I can't say that anymore. I mean, I can't say older is 87. I qualify. I'd say 75 is definitely older. 70 may be older. But, below that, starting to think younger. Okay.
Got it.
So again, if your doc mentioned it, and especially if you're up there in the 15 plus range, or even 10 to 15 range, and they say, we need to start dialysis, read my book. Look at all the information I give you to go over with your doctor. And my work and a lot of other people's work showed that your best long-term survival is, if you can, not everybody can, start below 5. And we're starting over 15, folks. That could be a lot of time off the machine.
Mm-hmm.
Okay. And if but you need to be able to get follow-up. I mean, if a lot of times doctors may put you on a machine because they don't trust that you're going to be coming back and take care of yourself, eat the right diet, and get the right follow-up. What is competitive risk of death? I mean, James, does that make any sense to you?
I have not heard that term, but I'm going to guess it has something to do with, it's comparing multiple things and which one is the best outcome, or Least likely to
competitive
kill you.
risk of death. Okay.
Yeah.
So it means we're all going to die of something.
Mhm.
Okay? And anyone with kidney disease say, "Oh, this is going to kill me." Wrong, wrong, wrong. Early stage kidney disease, it almost never kills you. The risk is for getting hardening of the arteries, strokes, heart attacks, heart failure. That's what kills people with early kidney disease. And same goes with later kidney disease. But the competitive risk of death means, okay, I'm 75, I'm 80 years old. My number is 15. And they come to me and they say, "Doc, my number is 15. Should I go on a machine?" And I've actually got something in my book that actually you can go with your doctor, and your doctor can look at it and say, "Okay, I'll put your lab data in, your medical history in. I could give you a ballpark idea of your risk of dying from, you know, a stroke or a heart attack versus kidneys." And for those people who already have, you got diabetes, you had a history of heart failure, you have a history of a stroke, history of heart attacks, getting on dialysis in that range is not going to have you live longer, and you may live longer without the machine. Okay, because there are other things that can kill you more likely, especially if you're an older person.
And the quality of life would be worse on the
Quality of
machine.
life, and we're going to get to it in a little bit, is not good. You wind up spending an enormous amount of time preparing for the machine, having surgeries on your arms to go on to hemodialysis machine. You wind up in the ICU a lot. It's not a great life at all. And if you're one of these older folks and you're in and your doctor's talking about it, say, "Doc, can we tune up my diuretics?" Because if you're taking the right water pills, a lot of people are not going on because they've got bad kidneys. They're going on the heart's weak. And if you use the water pills right, you can manage without the machine. A lot of people are going on because they got bad hearts, and their kidney numbers around 15. So again, if your doc say, "I want to start," say, "Why do you want to start?" Here's some reasons to start. Okay, if your doc's using the diuretics, the water pills right, and there's combination. They should not be just using one. They should use them in high doses, and they may need to use combination water pills. But if you got all those water pills, you can't manage your fluids, you need the machine. Be able to breathe. No argument. Let's say you got severe nausea and vomiting, losing weight, and you can't explain it any other way. You don't have a GI problem. That may be a reason to start on a machine. Very rare are the two reasons that are clearly indications. Something called pericarditis, fluid around the heart, extremely rare, or seizures, again, extremely rare. Less rare is what as a cause to go on a machine? You happen to know? Has to do with electrolyte, which we mentioned.
Is it potassium?
Yes, yes. Okay. Again, we say this many times on these talks about diet. Too many people obsess with potassium. You do not need to obsess with potassium. You may have a potassium problem when you get, let's say, below 10 on GFR, and sometimes below 15, but usually it's in that range. And there are lots of drugs to help control potassium. When I was practicing, it was only one. It was Kxalate. Now there's two others. It's something called Veltassa and Patiromer. So the potassium can be controlled. And if you can't, that's the reason to go on a machine. And again, most of you do not need to be on a low-K diet. I push plant-based, Mediterranean, My Smart diet, which is best for your cardiovascular health. And that's obviously got a good bit of potassium. Don't let your doctor start you by your number. Not a reason to start. And again, most of you don't start for life-threatening issues. You start for vague issues like, "Oh, I feel a little weak. My appetite's not as good." I mean, to commit to a lifelong dialysis, say, "Doc, I need a better reason than that." And if you are one of these older folks that's got really bad heart failure, and you're in a wheelchair. You're not walking. The fact is, again, this is the competitive risk of death. You may well live longer with non-dialysis conservative management. You can do most of the treatments that relate to kidney decline, kidney failure. Let's call it kidney failure because we're talking about stage 5, right? You can treat most of them with injections for your anemia, with maybe a little bit of restricting potassium if you need to, with water pills to take care of your fluids. So most of this can be managed without a machine. So again, why you put me on dialysis, doc? If there's a good reason, then no argument. Now, if you are planning to go on a machine, my favorite, there's a bunch of different types of dialysis. We don't have time to get into them tonight. If you look at my book, I go into those of you who are CKD 4-5. I separate my book with the earlier CKD 3s, 3A, 3B, and then CKD 4-5, because then you got to start thinking about what you're going to do potentially in the future, especially if you're a younger person. Number one thing for a younger person for sure is transplantation. Get on the transplant list when your GFR is 20. Get on the cadaver list and start organizing your family members. An unrelated family member's kidney does just as well as a related kidney. They do very well. So younger folk try to organize a transplant. Again, my choice for older folks and for people who are needing to do dialysis at home, which I think is much better than having to go to a dialysis unit, is something called peritoneal dialysis. We don't have time to discuss it. It's in my book, and that's the one that I would recommend. It's good. It's more gentle, and you don't lose your remaining kidney function, which is critical. One of the things that happens when you start dialysis is that remaining kidney function goes down fast, and that even a few units of kidney function, 2 or 3 units, has a enormous benefit for you. You don't want to lose that. And remember, older folks, we've talked about this in many of our shows, your normal level of GFR for your 70s and 80s and 90-year-old folks, normal level may be 45 to 60. So don't go crazy with that kind of number. And if you're younger, getting a preemptive transplant, never going on dialysis is the best way to go if you can arrange it. But I personally don't think you should get on to a transplant or do it early, like over 15 GFR, although a lot of centers do that. I'm not going to debate that, but that's my opinion. So again, if you're CKD 4-5, you need to educate yourself. My book has a lot of information on it. If you're a younger person, you want to make sure you get that thing in your arm if you're going to go on hemodialysis called the fistula. Get it in the GFR 10-15 range if you got good veins, because that'll be with you for decades, and it's your lifeline. Older folks, don't rush into it. Your veins are probably small. You're going to wind up having multiple operations. I would wait unless you're definitely going to go on a machine. And even then, it wouldn't be the worst thing for people to have a catheter for a little while. Or maybe something called a graft instead of a fistula, which takes longer to mature. Way too many dialysis-related docs do not push kidney transplant. If you're a younger person or a healthy older person, ask about it. Push for it, because that's your best bet. And I think, last thing I told you, I had mentioned something about the weight loss drugs. As your kidney function declines, and many people don't know this, your nutritional state gets worse. You're going to be fighting malnutrition, protein malnutrition. So as you're getting into CKD 4-5, especially then, don't be pushing low protein diets. It's not a good idea. And your survival is probably best if you maintain your body weight and maintain your nutritional state you maintain your muscle mass. Okay, I think we're going to try to get some questions in, James, and I'll let you choose them.
All right, I have one question I definitely want you to address because it's a common one that we get. It's something that people are always looking for. I know what word to search for. Here we go. So Leo asked, what's your take on herbal stuff as a cure for kidney disease?
Leo, this is dangerous. Leo, it's not just me. The National Kidney Foundation has a position paper. They recommend avoiding these herbal remedies. They are dangerous. There are cases, especially of some Chinese herbs called aristocolic acids in my book that have caused kidney failure. They're waste of money. They have no proof of efficacy. Stay away from them. Save your money. Use the medicines that work that we talk about in our shows here.
And what I find interesting is around the world, countries spend billions of dollars treating kidney disease. If there was a pill that they could buy for $99 or whatever to cure it, whoever makes that pill would be filthy rich. They wouldn't be pushing these on Amazon and Facebook. Since countries spend billions on kidney disease, they would love a cheap solution. So there is no cheap solution.
And it's not cheap to come up with a drug that works. And the drugs we mentioned tonight, the ACEs, the ARBs, the SGLT2s, and now a ton of work on the weight loss drugs, the GLP-1 or the aldosterone antagonists like finerenone, eplerenone, spironolactone. The work on these drugs by the drug companies cost many tens of millions, and they are big studies, and there's something called randomized control studies, good science, and they have to be reviewed by people like me and other experts to make sure that they've done the science well. It's a whole different world. This is stuff that really works. Don't waste your money on things that don't work because you're gonna delay getting the things that work, and that makes no sense.
Yep. Now here's a question we've never ever had before, Doc. This is a great question. It comes from Sal, and it's an opinion question. How do you believe artificial intelligence may change how we treat kidney disease? Do you have an opinion on that?
Good question. I have not given it a lot of thought, but what I will say is that it's been a lot of hype, and there's some discussions about artificial intelligence answering kidney questions. We're not there yet. What happens now with artificial intelligence is we hallucinate, not we. The artificial intelligence computers makes up stuff because all it's doing is gathering stuff in the literature. Mm-hmm. And I think that if in the future it's a question of trust. If people trust the stuff that researchers like myself or other hardworking clinicians, academic kidney docs, or whatever your field is, if they can accept the information that's been worked on and it's been reviewed and say, this is the proven stuff, and plug in stuff, and we trust the artificial intelligence to tell you, okay, what about these herbal stuff that we mentioned on Amazon, 6 different ridiculous nonsense products, okay? Versus what AI is going to tell you about what works. If they trust the AI, that's when it could really make a difference. But it's a question of trust. Unfortunately, we have a big issue with trust in our society today.
Now, earlier we were talking about the different ways to measure your kidney function.
Right.
And one of them started with the C. I cannot remember what the word was. So there's the blood test, because Tyrone's asking ways to measure your kidney function.
Cystatin A, Cystatin, cystatin C. It's just another marker. It's a test that laboratories do. It's more expensive than the creatinine GFR, so that's why it's not done routinely. That's the name of it.
Very good.
I got to answer this one. Evelyn's talking about Dr. Oz.
Oh yeah, the
um,
cure.
it's and I was telling my wife the other day, Sanjay Gupta, Dr. Oz. I mean, what people. I mean, it just breaks my heart. It's sickening, frankly, to see these people that are qualified physicians for money and for business to push this crap. I mean, it's a shame. It really is, and unfortunately, they are.
Yes, his
And,
question is,
and
what are your thoughts on his gummies that claim to cure
it's all
diabetes in
nonsense.
3 days?
And I read the other day about something on Facebook that Sanjay Gupta is pushing some other crap. These are all nonsense things. They don't do a damn thing. And I'm embarrassed to say that these are people that are physicians. Um, Pat's asking about Tai Chi. Great. Yoga. Great.
Well, yeah.
Any exercise, pushing a lawnmower, walking in your garden, playing with your kids, anything is good. Just get up and move, and that will be good for you. Yep. Trusted Melon says amlodipine makes you lightheaded and tired. Check your blood pressure. It may be because it's too low. You may not need to be on that much medicines. That's unusual. Amlodipine does not work in the brain. Other drugs like clonidine that James is on, a very strong drug, can make you sedated, can make you sleepy.
Yeah. That one knocks me
Amlodipine
out. I
doesn't.
take 2 of them at night, and an hour later, I am struggling to stay awake. But it's good for me because I take them at night, and it knocks me out so I can sleep until about 1 a.m. when I wake up.
Chris is saying I'm on dialysis. Is there a way it can be reserved? I'm not sure what you're meaning, but let me tell you just anecdotally. So I have personal friends that have been on dialysis or patients I know of, and they were on dialysis with GFRs in the 10 plus range. And there's a way to calculate what your remaining kidney function is, even when you're on a machine, and your doctor should know how to do that. And I've had people get off the machine because they're making plenty of urine and they've got 10 plus GFR, so that's possible. And
Now, would you say it's rare that someone gets off dialysis?
uh, with acute, like James,
Oh,
if you
yeah.
have acute renal failure, and let's say you have not had a long-standing steady decline in your kidney number, and your doctor put you on a machine, be sure you ask your doctor, hey doc, I listened to this Dr. Steve Rosansky, and he said you need to be checking if my kidneys recover. Not done routinely. Kidneys can recover, okay? uh, and salmon is great. I'm all for salmon, all for fish. um, and enjoy your food. Mediterranean diet, plant-based diet is fine. And let's see here. Yeah, well, somebody mentioned contrast diet. That's M. Foster's talking about contrast, which is X-rays. So when you have a decline of kidney function, a lot of people in the radiology think, "Oh, we're not going to give you contrast." It turns out that it's a lot less dangerous than it used to be. They're using what they call soluble contrast agents that don't cause as much kidney failure. That's another one that used to cause a temporary reversal of kidney function. Um, Sardines are fine, fruits are fine, uh, and if someone's on periton, if you're on dialysis, by all means, you need to be on a higher protein diet. Remember, I told you malnutrition is very common as you get worsening levels of kidney function. Um, yeah, somebody's talking about angiotensin too. I like that. Uh, I don't know some of these things I can't answer.
Yeah, they're
Uh,
probably commenting on something you had said at the moment.
yeah, a low GFR, Priscilla, is indicating if it's really low, if it's like 10 or less, that you're in an area that you need to start thinking about dialysis or transplant. His dad is at stage 5. I worry about him. Again, depending on your age, don't let him rush him into dialysis, and just make sure he's got a doctor that's willing to monitor him And if he's got a lot of other medical problems, talk about whether we can manage without a kidney machine, which we talked about. It's called
Yeah, he's
conservative management.
64
Yeah,
for
well,
Priscilla's dad.
yeah, that's fairly young, actually.
Yep.
Yeah. And so someone says the ads on YouTube make it hard to follow your conversation. What does that mean?
So for some people, YouTube interrupts the stream and runs
Oh,
an ad for them.
oh, I didn't know
And
that.
and
Wow.
YouTube is slowly getting more and more annoying doing that until
Wow.
people do what I do and you pay YouTube an extra $20 a month or something to not have those ads interrupt. It got so bad I
Wow.
couldn't watch anything on YouTube. I was like, oh, okay, I'll pay for it.
Yeah, I use YouTube a lot. I pay for the premium. I don't
Yeah.
know. I forgot what it
So
costs.
you don't see the ad. They're out of
Yeah, yeah, yeah,
control
yeah, yeah.
now. They're
Wow.
everywhere and they're longer. I my son on his iPad was watching a kid's video. It had a 2-minute ad break.
Mm. Wow, 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 wow. Uh, so
Oh wait,
somebody.
real quick. Someone
Oh,
asked,
go ahead.
Volsa asked, what is it that I take that puts me to sleep? It's the spear. How do you pronounce it, Doc?
No, no, it's the
Spironolactone.
clonidine.
Oh, the
Clonidine.
clonidine. The
Clonidine.
clonidine. That's right. The
Catapress.
clonidine.
Catapress or
Yeah.
clonidine. Same thing. Very powerful, strong blood pressure drug. I use it for people that are difficult to control, and I have them take it at night because it helps them sleep. It also gives you a little bit of a dry mouth.
Yeah, I used to take it one in the morning, and I could not get through the day. I would fall asleep at work, no matter how hard I tried to fight it. So I talked to my doc. He said, "Hey, take them both at night, both the little pills, and it knocks me out, and I am great."
Cool, cool. Yeah, a lot of a lot of the comments here have to do with what goes into people's mouths. I know people, and James has taught me this that's the thing that people think that they're going to cure it by putting something in your mouth. Other than
Yep.
these
Other than
pills
a
that
pill, an actual
these
pill,
pills
a
that are
prescription.
shown to actually work, um, most of what you put in your mouth is definitely not going to cure your kidney function. Uh,
Now Karen has something
yeah,
interesting here that I've never seen. Karen Marshall. She says her cardiologist said ACE inhibitors like lisinopril are not good for people of African descent. Have you heard of this?
wrong. Okay, so this is outdated information. So, without getting too deep in the weeds, we used to say calcium channel blockers may be better for African Americans. They may work better. Nonsense. Anyone with high blood pressure, drug choice number one is an ACE or an ARB because it not only can theoretically slow the decline of kidney function, it'll protect you from heart failure, from heart attacks. It has those cardiovascular benefits. Those drugs are really good. And the one thing I would say, and I found this out in my clinical practice, African Americans, ACEs or ARBs are fine with the diuretic, and they'll work a lot better with the diuretic. Any blood pressure medicine works a lot better with a diuretic. Um, so Adrian has 71, man, 21% kidney function. Can it be improved? Well, I don't know how old you're 71. Okay.
Yep.
It again, there may be things that are affecting it, like drugs or dehydration, but assuming it's stable at around 20%, it may be 20% for years. And the one thing I didn't mention on tonight's show, I say this often, is that older folks tend to lose kidney function slower than younger folks. So you may be 20 for a decade.
Yeah.
Don't rush into dialysis is my best advice.
Now it's 8 o'clock, Doc, top of
Okay.
the hour. But that
All right,
was a
James.
great one, and I'm glad you got to mention it because a lot of people they worry. They may think, "Uh-oh, my GFR is 21. I'm going to be below 15 right around the corner." But that isn't so. It could take you a decade to get there, and then you still got further to go, as Dr. Rose said. You got as long as there's no other serious issues, you've got to get down to 10 and then 5 before you got to worry about dialysis in many cases. So
Yeah, but
don't
again,
worry
older
too
folks
much.
may have heart failure, and
Yeah.
that's often a combination of heart and kidney. But again, if your diuretics are used right, you can delay going on a machine. I've done that
Yep.
for many patients.
All right. That is the end of our show for tonight. It's our first one we've done near the end of the month. And we did it because Dr. Rowe was over in Australia and New Zealand enjoying a vacation over there. And there's summer, right? Because they're below the equator. So it's winter here, summer there.
Yeah, absolutely. Yeah.
Yeah. I
Yeah.
hope to do those kinds of things one day.
Yeah.
You know,
And,
I think I've had enough snow.
Let me just make one plug. Australia,
Yep.
New Zealand, and I'm involved with people around the world because I'm involved with the U.S. Registry of all dialysis and transplant patients. They put people on dialysis much later in those countries.
Oh, yeah.
And they do the right thing. Why? They don't have as much of a dialysis business as we have in this country and other parts of the world. So,
Yep.
yeah.
I love that. All right, everybody. Thank you so much for being here tonight. Please leave a comment. Tell us, about yourself. If you have questions for future videos, I go back, I see these, and it helps Dr. Rowe and myself, as well as Jen, the dietitian, come up with more things to talk about to help you live better, live longer with kidney disease. All right, Doc, I'll see you in the next video, and I'll see all of you very soon. I got to figure out what my schedule is for Jen. I will also be streaming live on World Kidney Day, which is coming up on the 14th. Going to do a hangout, going to be on here, hanging out, answering questions, and just having a good time spreading awareness of kidney disease. All right, thanks again, Doc, and I'll see all of you in the next video. Bye, everyone.